Check, check. Audio testing. Check.
So I think we'll get started uh, because we have a long way to go with a lot of beautiful talks, and we have some amazing, illustrious speakers who have come all the way from London and various parts of India, and of course Bangalore, and we have two online speakers. So without wasting much time, how's Bangalore, by the way? Beautiful, right? So, with that thought, because last week I was in Chennai, it's hot. Bangalore is truly called the AC city. So, with this introduction of Bangalore, we are going to have major sessions on stereotactic radiosurgery and stereotactic body radiotherapy on the occasion of the inauguration of our latest CyberKnife, which has just got installed in Apollo Banarghatta Road. I would like to invite Dr. Vinay Ural, who is a senior radiation oncologist at Apollo Banarghatta Hospital, to welcome the August gathering.
Good evening, everybody. Vakratunda Mahakaya Suryakote Samaprabha, Nirvignam Kurme Deva, Sarvakarasya Sarvada. I just want to invoke Lord Ganesha on this auspicious occasion because we are going to start something new here with a new technology. The main purpose of this gathering is Radio X. That means we are going to see the changes what's happened and what is the future for us here. I thank Apollo Management for this opportunity to welcome. I presume Dr. Manish Mattu is going to join now, who is CEO, Karnataka and Central Apollo. Our beloved chairman, Pratap Reddy Garu, is going to join us soon with his note. And also, I want to thank Dinesh Madhavan, who is President, Oncology, India International. And of course, I want to welcome Gopi Lama, Marketing Head, for taking all this pain to come here, and the unit heads of all the three Apollo, Preetham, Dr. Yatish, and Uday Dauda. And I want to welcome all my consultants of Apollo Banaragata Road, Bang, Shayadripuram, and Jayanagar. And I also want to welcome all the consultants from other parts of the Bangalore and abroad. Now, I want to ask you, what is more important, the destiny or the journey? Or the people whom you travel with? I would say all three are important. Why? Because the destiny to reach, we need good people. And they have to be with us good and bad times. Correct? But what happens in cancer? It is not so easy. Once the patient knows he has cancer or she has cancer, it's a very bad news and it's a very devastating situation. From then on, what happens? It's very difficult. We don't know we are going to survive long or short, but the journey has to be better. The destination, whether the survival or no, we don't know. It does not happen to everybody. What we see in a Bollywood movie, a happy ending, like an Akshay Kumar movie. It doesn't happen to everybody. Because we have seen in India, as a middle income, low income country, most of them come at advanced stage. So what we have to do is we have to give the patient better care. And with this Radio X, what we have thought of, the idea is to treat the patients with radio surgery, wherever it's indicated. This radio surgery we will be doing maybe with Gamma Knife or CyberKnife or Linac based. For Gamma Knife experience, we have Ian Paddock, who has got a wonderful experience. Around 25 years ago only, he made a Paddock constant, what we have been seeing, inverse of RTOG constant for the conformity index. He has been authority in that. Similarly, we have from US and Europe, Natins from Netherlands, Erasmus, and also Sean Collins from US. So we are trying to combine all their experience, expertise, to see how better we can move forward. From India, we have Dr. Jadhav, who has immense experience in Linac-based radiosurgery and Zapex, it's a new radiosurgery equipment. We have Devnarayan Datta, Dr. Shankar, immense experience in CyberKnife, and Dr. Mahadev. So we are going to see how they are going to help us more to give patient better care. I have been in Apollo for the past 10 years. I've been very lucky, I can tell, because I was there in earlier institutes where we had the first center to get an radiosurgery in South India in my earlier institute. And now we had first true beam with radiosurgery with the new model in Apollo 5 years ago. And in 2024, with the Dinesh Madhavan and Manish Mattu blessings, we have the new CyberKnife. Now, what is the purpose of all this? We have physician, radiation oncologist, surgical oncologist, medical oncologist. The combination of all of us to enhance our knowledge and to give better care. And that is the purpose of this August gathering. So with this introduction and welcoming all of you, all the delegates who have come, with the main purpose of giving better care for patient, I want to hand over to the Vikramaya. Thank you very much.
Our beloved chairman, Dr. Pratap C. Reddy, wanted to be here, but he couldn't because of some other prior commitments. So he has sent a message across, and I would like them to play that.
Greetings, dear participants of radios, to bring life-saving technologies for many, many people across the world. And my special thanks for the faculty for bringing the very best of technology to the knowledge of people and making a significant impact in lives. I remember 1983, my intention was to see that before brings in for people the technology, the newer methodologies, and adaptation of various techniques to make a significant difference in the way they were receiving treatment and the difference it could make in their lives. I think we've got the first city in the country and the first technology for any hospital in this part of the world. But our Prime Minister slightly changed, adapting all the steps that I suggested. He said, let's quarantine. The robotic surgery, I made a significant impact. We got first robot for gynecology. Then we went on to colorectal surgery. Now practically everything we are doing with robotic surgery, including heart surgery, brain surgery, adrenaline surgery. All of these, I think, we made a significant impact. What did we transform? We transformed the greater precision in the surgical outcome for the patient, less complications, and he goes home early and happier. This has been Apollo's continuous journey in the last 40 years. I made this amount of transformation for people of the nation and people of the world, and I'm sure with all your future radios and vision will make a significant impact in treating the cancer patients, because that is one of the severest problems of non-communicable disease, which is a big threat for this decade and for the years to come. So I first want to congratulate all the participants and more importantly appreciate the speakers for bringing in this level of information for people so that we equally not only perform the best possible care, but tell others what they can do to make a difference in healthcare of the nation and the world. God bless.
In fact, we thank the chairman for giving us an opportunity to have the S7 CyberKnife in our unit. Now, the much awaited talk, the talk of the evening by Dr. Ian Paddock. He has come all the way from the United Kingdom. I would like to just introduce him. And in fact, I had heard him many times before in ISRS, that is International Stereotactic Radiosurgery Society. So Dr. Paddock is the first physicist who was the president of ISRS and the recipient of the Fabricant Award. Dr. Ian leads the British Radiosurgery Society and chairs the ISRS Certification Committee. A leading expert in SRS, he is responsible for 8,000 plus patient treatments and helped set up 100 plus centers globally. Known for his creating the Paddock Conformity Index and the Gradient Index, which he's a renowned expert in. Dr. Ian currently on the faculty of 5 of the top SRS centers, including the Queen Square and Genesis Care in London. Please give it up to Dr. Ian Paddock.
Well, thank you very much for that kind introduction. It really is a pleasure to be back in India after 16 years. So I was asked to talk about technology and expertise today. My disclaimer is that I perform a lot of ad hoc consultancy work for Electa. But I have received honoraria from Zap Surgical, Varian, and Accuray. But I work with a gamma knife, and that creates bias because we always favour what we're familiar with. And I think actually it's my work with the ISRS that's helped me identify that bias, and I like to think that maybe I'm less biased than I used to be. Now, has anyone heard of 23andMe? It's a kit that you get in the post. You take a swab from your mouth, and then they can analyze, they sequence your DNA, and then they come up with, they can look for BRCA genes, they can look for other genes that predispose you to certain types of cancer. And somebody mentioned today, I apologize, I can't remember who it was, the best kind of cancer care is early detection. So I thought this would be a good thing to do. And one of the things that it showed was where my DNA came from, where my ancestry is. And not surprisingly, it's Northern Europe. There's a little bit of Spain in there, but I'm part Viking, part Saxon. But there's also a 0.3% that came from elsewhere. It turns out that it's from the south of India. So I'm returning home, or at least 0.3% of me is. So we're all related. I thought that was kind of fun. So seriously though, let's talk about treatment platforms. So here we're talking about intracranial SRS platforms. And we do that by looking at benchmarking. But first, maybe we should establish what do we want from a radiosurgery dose distribution? What is the ultimate radiosurgery dose distribution? How can you say that one device is better than another unless you're actually setting the goalposts, if you like? And I would argue, in this case, we've got a falcine meningioma, and if we plot a line that goes through the tumor, we would ideally like to have 0 dose in the normal tissue, and then we'd like to have a very, very high dose in the tumor, and then virtually 0 dose to the normal tissue once we get out the other side. Now, clearly we don't have that, but if we can agree that that's what we're after, then we can start to benchmark. So I was first involved in benchmarking in 2016, where NHS England decided to recommission all radiosurgery services in the UK. So they withdrew our contracts, and then we had to bid for them again, of course at a lower price. But we also had to prove that we could competently plan, contour and plan and deliver our treatment. So this was an excellent opportunity of getting a snapshot of the capabilities of SRS platforms in England in 2016. And we published about that in Practical Radiation Oncology. So first of all, we had to choose 6 radiosurgery cases to plan. So we chose a case with 3 METs, one of which was in the brainstem, a case with 7 METs. Some centers at the time felt that was too many metastases, but also a small and a medium-sized vestibular schwannoma, a skull-based meningioma, and a pituitary adenoma. We used benchmarking indices such as coverage selectivity, the Paddock conformity index, the gradient index, but we also used one called the R50%. If you're going to use a single value, the R50% is really not a bad one to use, but it combines selectivity, so that's the absence of dose spillage outside the target, with the dose gradient. So if you get a low R50%, it means that your V12 is going to be smaller and you're protecting normal tissue. In fact, if you're treating an AVM or a MET to 24 gray, then the R50% is directly proportional to your 12 gray volume. So if we look at the metastasis cases here, we can see the green triangles are Gamma Knife, so they generally tend to come up with the lowest R50%. Just above that is the CyberKnife. And then above that tends to be the Varian Linacs. And then not quite so good the Electa Linacs. And then finally, as outliers, it was the 2 tomotherapy units. And in fact, both those units voluntarily gave up treating with radiosurgery with those devices, and they ended up moving their radiosurgery practices onto a stereotactic Linac. Now, there were weaknesses of that trial. Treatment time wasn't considered. And while some people will say Gamma Knife treatments typically take a lot longer to deliver, there was a Linac plan submitted that had 45 arcs, which I think you could comfortably argue is not realistically deliverable. And some centers admitted they couldn't actually plan the 7 MET case in a clinical setting because it took over 24 hours of treatment calculation time. So during the pandemic, sort of scratching around with something to do, and I got together with some of the original authors of the 2016 paper, and we decided to revisit it again. Why after just 6 years? Well, equipment's been refined. Treatment planning systems, we've noticed, have improved dramatically. And this morning I was talking about the precision planning system for CyberKnife being so much better than the previous multi-plan planning system. But there's also new equipment that's been launched, for instance, SAP-X. How does that compare with other technology? So we asked ourselves the question, have technological improvements led to a corresponding improvement in treatment plans? So these were the platforms and the treatment planning systems, because it's not just the platform, it's the treatment planning system as well as the treatment planner that is also very, very important. But we chose treatment planners that had at least 2 years' experience in their treatment modality. So we had Gamma Knife Icon, we had the CyberKnife from the Royal Marsden, we had an Electa Agility Linac with a BrainLab solution, we had a Varian TrueBeam with a BrainLab solution, we had a Varian Edge with Eclipse, and then we had ZapX. And we used the same 6 treatment plans that we previously used, because then we can compare and we can say, well, what are treatment plans like in 2016 and how do they compare with 2022? Are we getting better? But because it was 2022, we thought we'd add an extra case, which was a 14 MET case, 14 small metastases. And interestingly, in 2016, I was the only one that was proposing 7 brain mets to be included in the benchmarking study. And I found it really difficult to push that through. But in 2022, 14 brain mets, everybody agreed, it was no problem, it wasn't controversial at all. So it just shows how things have changed. So we agreed a prescription dose for each target so that we could compare like with like. But Linacs added a 1 millimeter margin for metastases, but no margin for benign disease, and that follows local practice in the UK. Prescription doses were reduced if planning with a margin to compensate for potential additional toxicity. The organ at risk tolerance doses were agreed in advance. For metastatic targets, we aimed for 99 to 100% coverage, but for benign targets, we reduced that to 95%, which really follows the traditions of European radiosurgery. So we looked at target coverage, we looked at selectivity, which I mentioned is the proportion of the prescription isodose inside the target, if you like, the proportion that's doing good. The Paddock Conformity Index, which is the product of coverage and selectivity. The Gradient Index, which is an indication of how steep the dose fall-off is outside the target, with a low gradient index representing a steeper dose fall-off. We looked at the R50%, which is a combination of gradient and conformity. We also looked at something called the Efficiency Index and Global Efficiency Index, and I'll come to that in a minute. But we also looked at treatment planning time and estimated treatment time. So this was the first data that really knocked me out, was how conformal the CyberKnife treatments were. They used fixed cones for their treatment plans. But you can see that they're the blue squares, they were much more conformal than any other technology. And then below them were really a mixture of Linac. Then maybe below that actually was Gamma Knife. And then last of all was Zap, which is represented by the purple circles. But if we looked at gradient index, we found that there was a correlation between the beam energy being used and the dose fall-off, with the lower beam energies representing a steeper dose fall-off. So you can see that the lower gradient indices here are from Cobalt-60, Gamma Knife, and from ZapX. So Zap is very good, as is Gamma Knife, at creating a steep dose fall-off. But in this data, maybe not quite so good at conformity. And then it tended to be the higher beam energies, particularly 10 MV, where the dose fall-off was poorest. And then if we combine conformity and gradient together to get the R50, you can see that the winners there tend to be Gamma Knife, which are the light blue circles, and the dark blue squares, which is CyberKnife. And also there's a little bit of Zap there because the dose gradient was so good with the Zap. This is just looking at the gradient index versus the conformity index. And ideally, we want to be at the bottom right of this chart because that represents the steepest dose fall-off and the best conformity. We were also able to ask those centres that have been involved in the 2016 study and the 2022 study, had their performance changed? And you can see the remarkable improvement in CyberKnife treatments there. So these are exactly the same targets being replanned just 6 years later. And that's the result of the precision planning system. But you can see also that the BrainLab solution was significantly better. And interestingly, it was GammaKnife that wasn't any better, but that's because in 2016, I was involved in planning the cases, while in 2022, they were planned by another physicist using inverse planning. And I just don't think that was maybe quite as good as conventional manual planning. And these are what the results look like for the benign targets. So we also looked at the efficiency index. This is a parameter that was recently published by myself and Alexis Dimitriadis in Journal of Neurosurgery. So we know what efficiency is, right? You know, you've got a light bulb, you feed in 100 watts of power, you get maybe 40 watts of light coming out, but you also get heat as well. Well, the heat's what you don't want. And in the same way, we can look at a treatment plan. We've got the energy that's delivered inside the target, that's what we want. And then we've got the energy that's delivered inside the normal tissue, that's what we don't want. And so we can look at how efficient a treatment plan is. It's quite difficult to calculate, but remember what we thought was the ultimate radiosurgery dose distribution. This would give an efficiency index of 100%. Well, in reality, we don't get that. We get somewhere around 30 to 40%, maybe 50% absolute maximum. But we can see here how the different planning system or different platforms compare with each other. And you can see certainly there that it tends to be the specialized treatment planning platforms that tend to do better than the C-arm Linux. And then if we look at the multiple METS cases, actually here, CyberKnife did exceptionally well, and you can see that from the red arrows there. If we looked at planning and treatment times, not surprisingly, it was the Linux that had the fastest treatment delivery. It was actually the GammaKnife that had the fastest planning time because their inverse planning system is extremely fast, and it tended to be CyberKnife that was longer. Now, I don't see that as a problem. You know, you're delivering a treatment that is going to affect the rest of the life of that patient. And if you take a little bit of time, what's the problem? I really don't understand this obsession with treatment time, faster treatment delivery, more efficiency. Really, we should be concentrating on better plans. So the CyberKnife plans, as I mentioned, were really exceptional. They were produced by the Royal Marsden. They typically plan to the 50% isodose. Now, traditionally, CyberKnife centers typically plan to the 80% isodose. And if you plan to the 50%, you actually get a steeper dose fall-off with really no extra problem apart from a hotter center to the target, which, if you're treating malignant disease, is probably a good thing. And I think the tide has changed on that. It used to be that a lot of oncologists felt that was a bad thing and we wanted a homogeneous dose through the target. While I think now centers are accepting that a higher dose inside the target might be a good thing. They used fixed collimators, not the Iris or the MLC. They did have the longest treatment planning times of any platform, and they didn't add a margin, which I think shows why the R50% was so good. There are study limitations. Planning times are self-reported. A C-arm Linux added a margin, and if you add a margin, you effectively smooth your contour that you're trying to treat, and it actually makes it easier to perform the treatment planning. But we've published this in Practical Radiation Oncology, and we said planning indices are generally improved, particularly for CyberKnife and C-arm Linux, while lower energies still appear to yield a superior gradient. So that's a bit about platforms. But what about, what about expertise. What's the platform that we need expertise with? Well, obviously, the platform that you're treating the patient with. But you know, there is a platform that we're all using, which is the MRI scanner. And I think it's really essential that we are experts in MRI. Because if you've got distortion in your MR images, you will have distortion in your treatment. And you can pretend that you're getting away with that because you're fusing your MRI to your CT. But if you have got a distorted MRI image, you are going to have imperfect co-registration with your CT, and that will introduce error. Also, it makes a difference because if imaging was perfect, then everyone would be outlining their targets the same. Now, I know there are small variations in training, but it's also the fact that MRI images can be interpreted. They're not as clear as night and day. And in this work by Helena Sandström, she tried to quantify the multi-observer variability of 6 targets for intracranial SRS. So there was a meningioma, a pituitary adenoma, vestibular schwannoma, and 3 single mets. And she asked 12 experienced Gamma Knife teams to outline and plan the targets. So she was using the same technology in terms of treatment technology. She provided the images. And these are some of the contours that came back. But if you overlay the 12 different contours from the 12 different centers, you can see there's quite a variation there, particularly with 2 of the brain metastases. And we can look at that in terms of the density, where the whiter areas are the common areas which all centers agreed with, and then the darker areas that you can see on the periphery are where less and less centers agreed. And you can create 3D volumes here. So we've got something called the encompassing volume, which is the volume that if one center agreed that that voxel was target, then it's part of the encompassing volume. And then you've got something called the common volume, which is the volume that all centers have to agree in. And you'd think that they were pretty similar. But in this case, the encompassing volume is 11 cc's, and the common volume is just 2.5 cc's. So that's over a factor of 4 difference between these 2 volumes. So this was the cavernous sinus meningioma. Yes, we know that there are enhancing structures around a cavernous sinus meningioma. You need some expertise there. I was really shocked at these results. Here we can see the pituitary adenoma. The ratio there was 0.37, so about a factor of 3 difference. The vestibular schwannoma was not as bad, but still quite shocking. The first large metastasis was really quite good, but this was the worst one, which was the medium-sized metastasis, where there was about a factor of 6 difference between the encompassing volume and the common volume. And these are the results summary from that. And what this shows us is that we need to be better at contouring targets, and we need to have clearer images. And we can only do that if we're experts in MRI. And in my 26 years using MRI to plan SRS, I wanted to share with you just quickly 1 or 2 pitfalls that you can have. One is relying on mobile scanners. When your existing MRI scanner is being replaced, sometimes you ship in a mobile scanner which comes in on a truck. You do your quality assurance measurements, everything looks fine. But then you don't take into account the fact that you've got cars that might be parking next to the MRI scanner. Cars are paramagnetic, they're lumps of iron, and they will affect the magnetic field, and they will affect the distortion. And we've seen when that's happened that we've had potential significant errors that if we hadn't detected would have gone on to become a misadministration of treatment. We've also experienced times when patients have attended with an underwired bra, and even though the MR technicians tell the patients, no, an underwired bra is no problem at all because that's a long, long way away from your head. Well, actually, it makes a difference to the homogeneity of the magnetic field and can create errors. Dentures as well. I don't know if these images clearly show that, but this was a metastasis in the pituitary stalk, and this would have resulted in a significant error if we had not re-imaged the patient without their dentures, because there was a significant shift. And then you get cases where you just have poorly tuned or optimized MRI. So on the left, we can't see a metastasis, and on the right, I don't know if you can see no, you can't. There is a tiny little lesion in the cerebellar vermis there, which we would have missed if we had just used that very noisy MRI image on the left. And this one here, you can see a sort of frontoparietal lesion, which is much clearer on the right. But also it makes a difference just windowing, optimizing the windowing of your images. And this is something that you can do for free. It doesn't require you to change your MRI parameters. It's just making sure that you don't have saturated images when you contour. On the left, we've got an MRI image which is highly saturated and inappropriate for contouring. If you do contour it, and then you create another contour where you re-window the images, you can see that the lesion appears to get smaller. Well, it isn't getting smaller, it's just that you're not saturating the images. You're reducing what we call the partial volume effect, and the partial volume effect tends to expand the target volume. And by doing that, we're actually able to reduce the target by 18%, just by re-windowing the image. You can also use time delay if you want to find more metastases. Give the patient a 15 to 20 minute break before you put them in the MRI scanner, after you've injected the contrast, and you will detect those smaller lesions, and they will certainly become more conspicuous. And that's now been published, as has the effect of slice thickness. The thinner your slices, the more likely you are to detect a genuine metastasis. And in this study that we published in collaboration with MD Anderson, we found that 13% of metastases would be missed if you used a 3mm scan as opposed to a 1mm scan. I know I'm running out of time. So how can we ensure that expertise and an optimal use of treatment platforms? And I wanted to make a quick plug for the ISRS certification service, which is something that I'm absolutely passionate about. The ISRS is committed to raising the level of radiosurgery in SRS treatment delivery around the world. And one of the ways that we do this is through the ISRS certification service. We have a comprehensive list.
We can wrap it up in another 2 minutes. Thank you, in the interest of time.
20 seconds more. We have a comprehensive list of certification standards. We perform end-to-end testing. We visit the center and investigate the expertise. And we have a growing family of certified centers which demonstrate optimal use of the treatment delivery platform and expertise. So to summarize, dedicated platforms are ideal in delivering the best treatments. However, it requires expertise in SRS and the platform used. Expertise in imaging may be as important as expertise in the treatment planning and delivery. But there's still a lot we don't know, and we should continue to question many assumptions that have become dogma. I believe that expertise doesn't always mean that we know more. Expertise should be partnered with the wisdom to identify what we don't know. Thank you very much for your attention.
We have time for questions.
Oh.
Any questions from audience?
I'm so sorry to run over.
I'm sure we know everything or we don't know anything to ask a question.
Well, please feel free to ask me after this meeting, at the end of this meeting, at the break.
We'll discuss about it at the end of the meeting. Any more questions?
See, as a clinician, when you want to buy an equipment, in very simple terms, if you could say, you know, there Zapex now, CyberKnife, your government, how would you go about choosing which machine to go in? If I see...
How do you choose your platform? I think you have to look at the clinicians that are going to be treating with it, what their expertise is. Do you want a platform for the whole body, in which case you're going to go for a CyberKnife or a stereotactic LINAC, or maybe an MR LINAC? If you're just treating the brain, then the Gamma Knife and Zapex come into the picture as well. It's a very difficult decision to make. And there are pros and cons with every platform. I'm convinced of that. Okay.
I have one question. Do you think protons can come to the extent of dose distribution like Gamma Knife in near future with the newer proton technology, not the earlier protons?
Well, I wouldn't argue that protons is newer technology. You know, Lexell was using protons before he used the Gamma Knife for radiosurgery.
I meant the newer way of delivering protons.
Yeah. So, protons are certainly good for some indications. I think for superficial tumors, if you've got a convexity meningioma, then protons will yield a dose distribution which is better than any other radiosurgery platform. If you've got a deep-seated tumor, actually photons do incredibly well. And yeah, if you've got, let's say, a pituitary adenoma, then actually you're probably better off using a CyberKnife or a Gamma Knife or a Zapex in terms of the dose fall off outside the target. But you know, it'll vary depending on your proton technology as well, because there's huge variations there. Sure.
That was, in fact, considering the uncertainties of proton, that also has its own set of limitations. This was an argument which I was having with my physics at Chennai. You know, the comfort level of shooting it at single fraction or 3 or 5 sessions, just like what we do for on the other frame receptor.
I feel uncomfortable fractionating because it doesn't really allow you to sweep those uncertainties under the carpet. I feel, okay, if you can treat with certainty with with photons, then that might be the better option. But obviously each case is individual. You know, there are advantages with protons as well in terms of radiobiology. We need more clinical studies in that area. That's what we're desperate for.
Yeah, I think we'll go for the next session.
Okay.
That was an amazing talk. In fact, we could go on and on with questions, but we'll keep it for the later time. I would like to invite upon Dr. Manish Mattu, Mr. Jerin, and Mr. Prasanna. Jerin and Prasanna are the physicists in Apollo Hospitals, Bangalore, and Dr. Manish Mattu is the Group CEO of Karnataka and Central India. I would like them to facilitate Dr. Ian Paddock.
Olympic season, so we are giving, handing over a medal also to Ian Paddock.
Thank you, Dr. Manish, Prasanna, and Jerin. The next keynote address is going to be an online one, and Dr. Anuradha would introduce the next speaker.
Good evening, everyone. I'm highly privileged to introduce our next keynote speaker who is going to join us online today, Dr. Sean Collins. Dr. Collins is the Director of CyberKnife Prostate Program at MedStar Georgetown University Hospital and a professor in radiation oncology at Georgetown University School of Medicine. He specializes in prostate cancer with advanced expertise in both stereotactic body radiotherapy, especially CyberKnife.
Great. dose was inadequate. So in the CAT series, a lot of the patients actually received 35 gray 5 fractions, which I think is too low to cure prostate cancer. Plus, they weren't doing intraprostatic dose escalation. So what we do now is we usually do guidance to MRI-defined lesions. And I do think androgen deprivation therapy is important when you're treating prostate cancer that's unfavorable. And it's important because there's probably microscopic disease. And we know in the CAT series that only 45% of the patients actually got hormonal therapy. What we have learned from our physicists, and by the way, Dr. Paddock's talk was spectacular. What we've learned from our physics colleagues is that tumor control probability is probably you have to give a higher dose in high-risk prostate cancer than you do in low to intermediate risk prostate cancer. And that makes sense because you have a higher burden of disease in high-risk prostate cancer. We also found great work from my colleague, Dr. Michael Zaleski, who I love listening to his talks. And he did an amazing dose escalation trial where he showed that if you look at biopsy rates 2 years after treatment, you really need to give about 40 gray to the prostate to have a low positive biopsy rate at two years. And to me, this is pretty important data and has greatly influenced what I do now. What he showed too is that it's even more important to do dose escalation in your treating intermediate risk or high risk. So specifically, in the unfavorable population, dose escalation is probably more important. And what he showed here is that use of androgen deprivation therapy and the radiation dose predicted how well you would do in these groups. So it's not only dose escalation. Dose escalation alone is inadequate. You have to do hormonal therapy and dose escalation. Our European colleagues have shown that it actually doesn't require that much hormonal therapy to improve outcomes. So they looked at EORTC 2291 phase 3 study, which was mostly unfavorable patients, and they looked at boosting the prostate to a higher dose, giving a higher dose than standard to the prostate for both groups, and then adding hormonal therapy for 6 months. There was an improvement in local control and an improvement in distant control. So what we've been doing is we've been combining our data with UCLA and Dr. Keyshawn, and he's been doing some amazing analyses. And what he's been showing is that when you utilize SBRT for high-risk prostate cancer, and you improve biochemical disease-free survival if you give hormonal therapy with the radiation. So it's now our standard to give at least a little bit of hormonal therapy when we treat high-risk patients with SBRT. He also showed that dose escalation actually, from 7 gray to 8 gray, improves outcomes with a hazard ratio of 2.15. So dose escalation is important, and also, but whenever you do dose escalation, there's always a risk that you can have injuries. So going from 7.25 to 8 gray increase the grade 2 toxicity. So whenever you do dose escalation, you have to make sure that you're doing it in a safe manner. One study that I thought was really important, which I'm glad that I didn't do, was 10 gray for the whole prostate or 9 gray for the whole prostate, because this dose escalation ended up at a very high rate. It had great PSA control, but had a very high rate of late complications. A 6.6% rate of GI grade 3 toxicity is way too high for prostate cancer patients, most of which are probably going to end up dying of something else, and they're going to live a long time with the side effects. Colostomies are not acceptable. What Dr. Zaleski showed is that most of the recurrences after SBRT were predominantly in the dominant intraprostatic lesion on the MRI. So to me, this is very important in correlation with the FLAME study that showed using conventional fraction radiation, boosting the MRI-defined lesion to a higher dose, going from 77 gray to the entire prostate, to 77 gray to just the entire prostate, and a 95 gray boost to the prostatic nodule, actually improved, had no effect on toxicity, both GU and GI toxicity, and actually improved biochemical disease-free survival from 85% to 92% with very little increase in toxicity, if anything. Now, the FLAME trial was great, but what it was not set up to be like doing a great job of the boost. So no margin was added to the boost. So to me, I mean, if you had no margin to the boost, you better make sure that you have a really accurate device giving the radiation, or else you're going to miss. Boost dose was reduced to make dose constraints. So only 20% of the patients actually got the 95 gray. Imagine that what the difference in biochemical disease-free survival could have been if everybody actually got the 95 gray. So I would argue that when you're doing SBRT and you're boosting to intraprostatic lesions, certainty matters. Like I use the CyberKnife every day, and we use a real-time tracking system that provides updated prostate positioning and corrects the targeting of the therapy during treatment. And I think this is specifically very important when you're boosting lesions, specifically lesions that are right next to the urethra or right next to the rectum, because that's where accuracy really matters. I actually, to me, also like in the future, I see us doing focal treatments, and if you're going to do a focal treatment, I think accuracy is even more important. So I'm happy that I use a highly accurate machine with continuous image guidance. So what we're finding is that although we do have failures locally in the prostate, a lot of the failures are actually outside the prostate. We've been using PSMA scans for about 2 years, but I know in India, you guys have been using PSMA scans for probably a decade. And what we find is that there's a mixture of recurrences. This is great data from top of world showing local recurrences happen, regional nodal recurrences, distant recurrences, and sometimes there's a combination of these. So how do we deal with these patients? So for the focal recurrences in the prostate, what I wanted to do now is I've treated 20 patients with local recurrences, PSMA local recurrences in the prostate. And first of all, they come in a wide variety of locations. Some are anterior, some are posterior, some are central. And you actually can treat this as studies looking at a focal HDR brachytherapy to treat these recurrences. I'm actually now using the CyberKnife to treat these recurrences. I actually think in some ways it's a little, these PSMA images that we combine for the treatment plan are not perfect. So both have pretty good dose fall off. Both give a higher dose in the center of the target. But SBRT is definitely easier to implement, in my opinion, than HDR, specifically when it comes to focal treatments. But if you're going to do focal SBRT on the prostate, I think you need a really accurate machine, so I am happy that I have the CyberKnife to do it. By the way, the Europeans, once again, are doing a great job. They're doing the studies to figure out what the right dose is when you're doing these focal retreatments, and I hope that this trial is successful and that they continue to do more trials so we know exactly what the right dose is. Right now, I copied Don Fuller. He does 34 gray in 5 fractions, so I usually do 34 gray in 5 fractions for PSMA-determined local recurrences in the prostate after SBRT. We've treated 20 patients. I've seen minimal toxicity, and they're actually now months to years out. There's minimal acute toxicity. There's actually less acute toxicity than when you treat the whole prostate. And I've seen no warning signs that we're going to see higher doses, higher late-grade toxicity. So what do we do with the nodal oligo recurrences? So historically, it was difficult to identify these recurrences before we had PSMA scans. These newer PET agents are showing these in a timely manner. So as the PSA starts to rise, I usually get a PSMA scan around 0.5. About 60 to 70% of the patients have these nodal recurrences. Most of them are in the upper pelvis, lower abdomen, and this is, I think, a highly curable disease, or at least a favorable prognosis disease. It has low disease burden and has favorable biology, from my experience. And early evidence suggests that metastasis-directed therapy of these lesions can improve care and definitely kick the can down the road. But a lot of patients, unfortunately, end up recurring in the nodes above the target. So what do we do with these patients? How do we incorporate humoral therapy into these patients? Or what target volumes do we use? So the treatment volumes that you can use just focal SBRT, or you can treat the whole upper pelvis and the whole lower abdomen. I like the compromise on doing the involved field because it has less side effects than the whole pelvis. It does have a little bit more toxicity than doing focal treatments, but it's all grade 2 and it's all acute. So in my opinion, the right approach is the involved field approach, which because PSMA scans are not perfect, they cannot see cancer cells less than 0.5, cancer deposits less than 0.5 centimeters. This is our approach to doing it. We include, if you're involving the external iliac, we usually treat the external iliac, the operator, and the internal iliacs. If you're involving the common iliac, we usually treat bilateral common iliacs. If you're involving the periaortics, we usually just treat the periaortics. And this is just an example of how I do this using the CyberKnife. We usually, especially it's very common for patients to have low periaortic and upper pelvic lymph node involvement. And we'll use, I think one of the best things about the CyberKnife is its spine tracking. And you you can actually use the spine tracking when treating periaortic lymph nodes. This allows us to do, because the CyberKnife is inhomogeneous by nature, it allows us to give dose escalation to these involved nodes. And I think it's a really, I feel very comfortable giving high doses of radiation next to bowel using this approach. And our paper's under review at Frontiers in Radiation Oncology. And what we found is that with these kinds of treatments, acute toxicity is about 10% rate of nausea, 10% rate of diarrhea that's transient, and a very, very, very low rate of any late grade 3 toxicities. So how do we incorporate the systemic therapy? I don't know, for these patients, I don't like putting patients on hormonal therapy for the rest of their lives. I usually use intermittent ADT. And this approach allows, first of all, there are some of these men that we will cure, maybe it's 10 to 20%, and I don't want them to be on hormonal therapy for the rest of their lives. But I do want to intensify when a patient has a cancer more aggressive. I do want to intensify.
Can you wrap it up in another 1 minute?
Okay, sorry. So the NPRT assisted intermittent is our approach. We do upfront consolidation for these patients. We get a PSA, we get PET imaging, we radiate their novel disease. We start hormonal therapy. If the PSA drops, below less than 0.2, we stop the hormonal therapy. We check the PSAs. If the PSA rises again, we treat the nodes and we do the circular. If their PSA never drops, then we intensify the hormonal therapy. And the hormonal therapy that we're using is Robotic. It's a new drug. It's a pill. I like it because it allows me to control. Patients like to have control over their hormonal levels. They like to be able, if they don't like it, they like to stop and have their testosterone recover quickly. And the advantage of this drug is that it suppresses the testosterone to a low level. It does it very quickly to very, very low levels. And testosterone recovery happens quickly after you stop, so it gives more power to men to control hormonal their testosterone versus Lupron, which almost takes a long time to wear off. We're looking at other types of hormonal therapy that might have less side effects for these favorable populations. Enzalutamide is one month, darolutamide is another one, apalutamide is another one. And I think these are going to be very important in the future care of intermediate risk prostate cancer and in men with oligonodal recurrences. And there's a trial ongoing looking at this impact of this on sexual function. And we should be using more hormonal therapy in men with low burden metastatic cancer, as shown by the STAMPEDE trial. It actually improves survival. How many drugs improve survival at 3 years by these numbers? So to me, using radiation to the prostate in men with low metastatic burden should be used more commonly. Thank you for having me. I'm part of the Actor Exchange. It was an honor to present today and have the support of the Actor Exchange while I was doing it. And thank you very much. We'd love to answer any questions.
Excellent talk, Dr. Sean. I think we can take 1 or 2 questions max in the interest of time. So there are no questions. We'll go to the next topic. Thank you, Dr. Sean. It was an excellent presentation.
After the excellent talk by Dr. Sean Collins, we'll go to the next set of presentations. Unfortunately, Dr. Devnarayan Datta is a little under the weather. He's not keeping well, so we might be going in for the, we will be going in for the panel discussion. I would request Dr. Priya to introduce the moderators and the speakers.
We'll go ahead with our first panel discussion regarding management of benign brain tumors and management of recurrent gliomas. For this, I would like to call on the dais our panelist, Dr. Ravi Verma, Head of Neurosciences and Senior Consultant Neurosurgeon, Aster Hospitals, Bangalore, Dr. M.S. Baileyappa, Director of Radiation Oncology, Aster Hospitals, Bangalore, Dr. Vijay Agrawal, Lead Medical Oncologist, Apollo Hospitals, Bangalore, and Dr. Satish S., lead neurosurgeon at Apollo Hospital, Bangalore. To moderate this session, I warmly welcome Dr. Shankar Vangipuram, Senior Radiation Oncologist at Apollo Cancer Center and Apollo Proton Cancer Center in Chennai. With over 24 years of experience, his primary focus is on functional radiosurgery for neuralgias, movement disorders, epilepsy, and psychiatric conditions like obsessive-compulsive disorders, benign intracranial tumors, and extracranial radiosurgery for cancer of lungs, liver, pancreas, spine, and prostate. Over to you, sir.
So, at the outset, I need to congratulate my colleagues and the management of Apollo Bangalore for getting ready for the state-of-the-art technology. So, how many minutes do I? 20? Okay, fair enough. So, what we'll be doing is flying through a few of the important concepts in the management of malignant and benign brain tumors. So we have two wonderful neurosurgeons, Redonk and Senior Most Redonks and Medonks. So without much ado, let me just draw your attention to the first case capsule. We have a 52 years old gentleman, alternating constipation, diarrhea, bleeding PR 2 months, colonoscopy revealed a growth in the junction of the transverse and descending colon, biopsy adenocarcinoma. Dr. Vijay, the first question to you, what this PET CT was done, liver mets, there was axillary lymph node metastasis as well. So what chemo or what is it?
We do a biopsy to confirm what it is in the molecular testing.
Sorry?
We do a biopsy to confirm adenocarcinoma and send it for molecular testing.
Is there some resound which I'm getting?
Okay. I'll speak. On the biopsy sample, we would send it for molecular testing.
Yeah, this was almost like 7-8 years before.
7-8 years ago.
Yeah.
Okay.
Yeah.
And the PET scan, you said liver mets was there.
Yep, liver mets. It was a metastatic disease.
So we would start with some upfront chemotherapy.
Perfect.
And I would also talk to our surgeons to see if the liver met would be resectable or not.
Okay, so fair enough. So this patient actually received Folfox and cetuximab, and KRAS was done for that patient, and that was the reason probably she was put on cetuximab.
Yeah.
6 cycles were completed. And when the patient was actually receiving the last cycle of chemotherapy, developed symptoms of raised ACT, and as you can see here, the patient has developed a solitary 3.5 centimeter cerebellar lesion, and that's symptomatic. So that's solitary again. And the question is, obviously to Ravi sir, would you like to go and do surgery for this solitary lesion or just leave it to Bilyappa sir for frying? You know, I mean, it's entirely. So we have a solitary lesion there.
So we definitely it's a large lesion.
Large lesion, yes. It's around 3.5 centimeters, 3.2 centimeters.
2 reasons. One is, of course, from the ICU point of view.
Okay.
Such a huge lesion, I think we need to take it out because of the very presence.
So we have a patient, again, this was a PET CT scan. At the end of the completion of the chemotherapy, the response was only partial. It was not complete. And there was a progression of the disease. And as I said, there are 3 sites. This essentially fits into oligometastasis situation. So obviously, surgery is something which you would recommend for that, followed by Bilyappa sir for radiosurgery, cavity radiosurgery or something.
See, adenocarcinoma, liver, even with liver secondaries, we have a long-term survivors.
Okay.
Okay?
Okay, so what's the plan you would suggest then? Would you advise for surgery followed by cavity radiosurgery or whole brain radiotherapy or just...
Liver is a solitary lesion, right?
Right, sir. It's just solitary, but it's large.
Large lesion.
Yeah.
I'll maybe take an opinion from the surgeon.
Surgeon, fair enough. So surgeon can obviously remove it. It's very simple surgery. Yeah. So this is what you would...
Yeah, I think I agree with Dr. Ravi because it's a large cerebellar secondary, and we do know that being a solitary secondary and there's already brainstem compression, in all likelihood it's going to develop hydrocephalus as well.
Yeah.
So I don't think so that such a large lesion can be managed only by radiotherapy. If we have two factors in our favor, that if there are other options as far as, I'm not very sure about the chemo, what other options are there, as well as the longevity. So if the patient is fit for surgery and at least the life expectancy is reasonable, then I think the risks of doing surgery for removing the cerebellar lesion is not very high.
Fair enough. Okay. So what... once this is the patient whom we got, I discussed with our Madong at that time. I was in Mumbai at that time. So, reputed senior medical oncologist who planned to give immunotherapy. So they have actually done MMR and MSI at that time. And it was positive for immunotherapy. Immunotherapy can be explored. So, but then this patient is actually related to a neurosurgeon, brother of a neurosurgeon. We just gave a thought about using synergistic effect of immunotherapy and radiosurgery. So what we did is we went and did radiosurgery for the cerebellar lesion. Now, the immunotherapy was also given along with the radiosurgery. 3 months later, you can see everything else gone. So essentially, what we have done is triggered a systemic effect with radiosurgery alone. So this particular effect for neurosurgeons specifically, and Madons, of course, you must have heard about what is called as abscopal effect. You hit at one point, you get results at the other locations as well. It's not necessary that we need to use a knife in every case because there is enough armamentarium right in there for us to make sure we get the results, intended results in a much better way. So now Biliappa sir, of course, it's a very basic question, but again, because we have neurosurgeons there, why radiosurgery here is immunostimulatory unlike the regular conventional radiation therapy, which is immunodepleting?
Come back.
Here we are having radiosurgery, the surgical doses of radiation. What has been delivered is immunostimulatory. It has triggered something. Unlike the conventional radiation, which is more depletary, it causes immune suppression.
It's a known factor, like, when you give SBRT, a very high dose.
Precisely.
Like, it adds to the immunotherapy.
Yeah.
So we have seen better outcome.
Fair enough. So the simple point which I would like to draw your attention to is whenever the tumor is hit, there are helper T cells coming down there, right, to repair whatever is adjacent there. Now when you're doing the treatment conventionally, every time you deliver the treatment, the helper T cells are dead. They again come, again it's hit and it's dead. So that's precisely the reason why conventional radiation is more immunodepletary. In radiosurgery, the treatment is done in just single session or maybe 3 sessions based on the size of the lesion. In this particular case, we have done in 3 sessions for the simple reason that we wanted the immunostimulatory effect to kick in. Now, whenever we are doing radiosurgery, there are 3 things which we essentially, 4 things essentially we need to look into. Number 1 is the dose and the fractionation, what we are going to do to get the immunostimulatory effect. Number 2 is the type of radiation what we use. Number 3 is the sequencing with the immunotherapy. And lastly, what should be the treatment fields which needs to be included. So essentially what happens here is radiosurgery actually activates the viral defense mechanisms. That's what is called as cGAS-STING pathway. The final byproduct of this activation is interferon 1. And this interferon 1 is needed to attract the helper T cells. That is precisely the reason why with particular dose range you're going to get more of interferon. Now, the dose range which was calculated is essentially ablative dose. You can't be exceeding more than 10 gray or 12 gray. It should be less than 8 gray. Then only it is immunostimulated. As you can see, at higher doses, the effect is lost. Abscopal effect is lost. You're getting it at ablative doses. And precisely that happens because at higher doses, it produces exonucleases, and this will go and inhibit the gasting pathway. And therefore, it is less effective at higher doses of radiation. The most important thing which we need to keep in mind is we are not supposed to keep these patients on steroids, immunotherapy, because the moment you keep these patients on steroids, as you can see, the effect is gone. So essentially, when you're trying to synergize two modalities for better outcomes, we need to understand the biologic nuances properly and then attempt to integrate it. And post this case, we have done induced abscopal effects in a good number of patients. Now, let me just draw your attention to the second case. This was a patient, 20-year-old, presented with dysphagia, occasional, 30 days duration, and a 7-nerve palsy. MRI, you can see, pons mesencephalic cavernoma with hemorrhagic signs, history of bleed 4 months. Now, the question is, what is the bleeding risk for this brainstem cavernoma? Probably Satish can.
Yeah, so the presentation was with a bleed, isn't it?
Yeah, no, bleed was over, patient recovered. Again, the patient was consulted by the neurosurgeon, and we had a discussion on this. What is the best strategy?
So what is the age of the patient?
20 years old, sir.
Yeah, can we go back to the axial image?
Yes, sir.
Yeah, so this is in the lateral aspect of the brainstem, just anterior to the IAC. Yeah. So it is in a very operable level as far as the operability is concerned. So we have to take into account the age, any prior history suggestive of a prior bleed was there, that determines there's a higher risk of rebleed. So brainstem cavernomas, we do now understand that if there has been a bleed and there is a very high incidence of rebleed. If there has not been a bleed, then we have to evaluate to see whether if it is symptomatic and approachable, because the pile, it's just a pile here. So I would again think that with intraoperative neuromonitoring, excision risk is very less, I mean, very acceptable, if the patient is otherwise fit for surgery. And we do know that conventional
patient
radiation
is fit for surgery.
Yeah, so we do know that conventional radiosurgery, at least majority of the literature says, it's not favorable for radiosurgery.
So one point is very clear, brainstem cavernomas, typically the bleed risk is very high, and it is to the tune of 30 to 40% compared to the cerebral cavernomas, superficial cavernomas. Now, that risk actually gets much more compounded if it is located in the pontomesencephalic region. Having said that, any intervention we do, surgery is no doubt the best curative option we can find for any of the benign lesions. Forget about cavernomas, any of the benign lesions. Now, having said that, this patient had consulted 3-4 neurosurgeons. Everybody have given a good picture, but also the patient is more interested in understanding the risk of surgery. Dr. Verma, can you please enumerate what could be the risk of surgery?
Most importantly, I think it's a very accessible area.
Yeah.
And with microsurgical techniques.
Yeah.
Adequate technology, I think.
Precisely. So what are the yeah.
So probably because it's very close to the facial cortex, the facial nerve, so there could be a facial nerve involved. But again, with precise surgery, that can be avoided.
Precisely. So what are the neurosurgical adjuncts that you use when you're doing the surgery for?
So probably we require navigation. We require
brainstem event.
And a microscope, microinstruments, and neurophysiology throughout this.
Precisely, yeah. So essentially we need to have that neurophysiology. That's more important when we are trying to do surgery at this particular location. That's very crucial. Now, again, as Dr. Satish has already alluded to, bleeding control with radiosurgery is always questionable because we are dealing with an angiographically occult lesion, right? It's not visible on angiography. So therefore, we really cannot say just a slight decrease in the size of the stable disease. Is it really the meaningful way we can actually define whether the patient is actually getting benefited or not? Now, interestingly, the world has still been practicing radiosurgery. In fact, radiosurgery is essentially used in 2 locations in the context of cavernomas. It's in the brainstem and in the mesial temporal lobe regions, specifically with epilepsy, right? There are, again, reasons. I mean, we have done in only 1 case. All the cases we have referred for surgery only, if it can be done safely. Now, when a systemic meta-analysis was done with radiosurgery, as I said earlier, this is angiographically occult. You cannot document the decrease in the, whether it is obliterated or not. There has been a statistically significant decrease in the bleeding risk of the patients who are treated with brainstem cavernoma. So essentially this patient we have discussed about the options, the risk. Of course, we had all the neurophysiologic monitoring, everything, neuronavigation. Patient was more inclined for non-invasive option. So we have offered radiosurgery for this patient. And honestly, 2 years later, you can see the cavernoma getting disappeared. But this is pretty unusual because the very next case, which we have done a couple of months later, with 10 years follow-up, there has been a decrease in the lesion dimensions, but still I could see something. Patient is totally asymptomatic, no bleeding risk. So for the few 20-odd patients that we have done at these critical locations over the last 2 decades, we have seen rebleed rate happening only in 1 patient. So honestly, if the surgery is critical, I mean, if there is a meaningful, important, what I would say, risk involved, obviously this also can be one of the options that can be explored. We have treated spinal epidural cavernomas post-op recurrences, not the treatment naive, recurrences of the cavernomas in the spinal cord also can be treated, and we have done in few of the patients. You can see how the lesion has actually regressed. So the corollary here is, yes, this also is one option which we are exploring. Now this is another patient who is 47 years, female, with headache, blurred vision. You can see cavernous lesion. I'm sure Satish sir, Verma sir, without the diagnosis very pretty forward, cavernous hemangioma, brilliantly fluoring on T2. Now, essentially there are 3-4 differentials you can see here. How comfortable you are doing surgery for this lesion?
So, as far as the diagnosis is concerned, this is a fairly specific from
radiologic
MRI images. It looks like to be a cavernous angioma of the cavernous sinus.
Exactly.
Do we have a DSA for this? And
DSA also, this is the DSA, yeah.
So, is there a good cross circulation? There's no good cross circulation,
Usually you find hypervascularity right there. We are not seeing that.
So this mid-fossa cavernous angiomas are really a difficult challenge surgically.
Precisely.
I would think that unlike even other cavernomas, these are a little more responsive, I believe, for radiosurgery.
Precisely.
So I would probably err towards radiosurgery.
Perfect. That actually begs the question. We have the meningiomas, schwannomas, all this as a differential diagnosis. But radiosurgery is definitely the first option we choose for the lesions which are located in this particular area. Now, when we are doing radiosurgery, what you can see is if it is hemangioma, the regression is very fast. Unlike what you're seeing with meningioma or neuroma. So that's one of the surrogate we use, and you can see here the lesions within 6 months to 2 years and 24 months, such a large 2.5 centimeter hemangioma getting fired off. And this is very typical of hemangiomas, the regression rate is usually 70 to 80% in the first 1 year. Now the fourth particular case is a 31 years female who presented with pulsatile tinnitus, 3 months old. Of course, the diagnosis, as you can see in DSA, it's a transverse sigmoid sinus DAVF. Patient was attempted embolization twice. First time, it's transarterial using Onyx. Second time, liquid embolizate was used. And what you see is the latest angiogram, super selective meningeal and right occipital shows DAVF recurrence, no cortical venous drainage. What is the option?
So the reason for the failure of the endovascular was?
Endovascular. See, DAVFs classically the first option is endovascular.
Exactly,
There is
and
no
most often it will be successful.
Usually, but the recurrence rates are also very high. It's not a foolproof 100% option for treatment as well. Of course, surgery is the best option, but again, you have the reservations there.
Correct.
But the primary treatment is endovascular necessity.
Yeah, either one could have used a
Especially endovascular for a dual AV is the best.
Yes, sir. This patient was attempted twice. What you see is the latest DSA and super selective DSA shows meningeal and occipital feeding vessels.
Dr. Shankar, another 2 minutes.
Yeah, this is the last case. So honestly, yes, when we are doing, of course, all of us believe we have this grading system what we use, and essentially it's a benign, there is no cortical venous drainage, and therefore we have offered radiosurgery for this patient because endovascular is the first option. Surgery is reserved only for high grade. Radiosurgery is essentially for low grade, not for high grade. And as you see here, this patient, we have done radiosurgery within 36 months, 3 years, you can see very good result. So the point here which I'm trying to make is specifically type 1 symptomatic or asymptomatic type 2, where the bleeding risk is very low and there is no significant disability. This is a very good option which we explore. And the second important area is carotid cavernous sinus DAVFs also. These areas also can be explored for radiosurgery. And undoubtedly, if we wanted to make sure we choose our battles carefully, make sure choose only those patients who do not have the cortical venous drainage for radiosurgery. You know, that are the patients who actually really benefit with radiosurgery as an option. The last case is a patient who's an 18 years old teenager, headache, seizures. DSA you can see left temporoparietal AVM, feeders, PCA, PCOM, MCA with deep and superficial drainage, nidus size 4.5 centimeter.
This is a Sputzler grade 4.
Yes, exactly. So what option?
Multi-compartmental as well, and it's not a very compact one.
It's not.
From the MR, it looks to be quite diffuse also.
Precisely.
So primarily, if it has not bled, I would think that surgery, upfront surgery is going to be quite tough if it is not embolizable.
Precisely.
And if it is not embolizable or only partially embolizable, again we know from data that a partially treated one is worse than just allowing it for its natural
The
history.
bleeding risk is very high.
Yeah, so probably radiosurgery.
So, no. So, doctor, you want to do embolization or something?
I had a couple of
pre-operation.
cases like this, not surgery, but sequential embolization.
Precisely.
Irrespective, every 3 months to 6 months we embolize partially, one by one, and then we've been able to achieve.
So, again, as Dr. Satish has already alluded to, embolization will be more small sectoral. It cannot be total. You can't go full-fledged to go and knock it off. Yeah. Again, there is enough evidence which is available now, which has shown you typically use Onyx 18 or 32, right? So we use Onyx 18 routinely in the clinic. That causes a lot of artifacts.
Dr. Shankar, can we wrap it up?
Last slide.
Yes,
Yeah.
thank you.
So that causes a lot of artifacts. So therefore, what? Yeah.
Planning becomes.
Yeah. So we really have a big problem, and therefore, we have done radiosurgery for this patient without embolization. We attempt preoperative embolization only in two clear angiographic situations. Number one, if there is a fistula. Number two, if there is an aneurysm. Because fistulas are typically radioresistant, and therefore you cannot really go and do, radiosurgery. That the failure rate is very high. In fact, we have coiled fistula later on after the radiosurgery is completed and nidus is operated. And you can see the results of this particular patient post-radiosurgery. We have done volume stage radiosurgery, and we have done a lot of patients. In fact, we are one of the high volume center for Spitzler, intermediate and high-grade AVMs. We have done tons of it, and we have seen better results with integration of multimodal approaches. And of course, one thing which is very important is we have treated patients who had multiple AVMs as well and recurred and salvaged with radiosurgery. And this was one patient, probably the first patient whom we have done proton radiosurgery as well. And interestingly, this patient had a lesion in the periventricular area, in the caudate and near the corona radiator. We have done proton radiosurgery. We have to delineate the corticospinal tract and the optic radiation, and you can see pre-treatment and 3 months for treatment. Usually the response lag time is around 3 to 4 years, but in proton we are able to see a faster time. And this is a rapid fire. Can I have 1 minute? Yeah. So this is a rapid fire session for the neurosurgeons. This was a post-MVD failure patient who had MVD failure, not interested in redo. So we have salvaged with radiosurgery, and you can see the responses. We have done nearly 350 trigeminal radiosurgery, which is probably the highest, and we have published that as well. This was a patient who had
average time from doing the procedure to the effect. Average time it takes from radiosurgery to response.
Oh, that's what I was trying to tell you. These responses, what you're seeing, are immediately after the treatment. It depends on, in fact, we have written a paper on this. How early do we get? You don't really need to wait for 3 months or 4 months to get the responses. We have analyzed some reasons as well, but because short of time, let me just fly you through a few of the questions. This was a patient TGN with T2 hyperintensity in the pons. Then again, there is no neurovascular conflict. The first differential was herpes, which we thought, but patient was not having it. So we have evaluated the MOG antibody, and we have salvaged with radiosurgery. This patient was doing well. And this patient had hemifacial spasms with trigeminal. We have done dual targeting of the dress as well as the trigeminal dress and the VCF bundle. And immediately after the treatment, you can see. We have done for glossopharyngeal neuralgia as well. All these patients whom we are showing is actually they are consulted. We do joint consultation along with our neurosurgeons. We make sure the patient understands the risk of all the procedure. And this patient was actually starving for almost like 6 months, had 4 idlis immediately after the treatment. And of course, this is something which everyone encountered, TDPD. The first option, no doubt, is deep brain stimulation. And this patient, at least in our country, couldn't afford DBS. So we have done lesioning, and exactly after some probably 3 days, you can see how the tremor has actually vanished. Dystonia, we have done pallidotomy, and these patients are really done well. Hypothalamic gelastic seizures, hematomas, post-RFA failure, we have salvaged with radiosurgery. Or similarly, the insular epilepsy as well with FCD, incomplete resection. Insula is one area where neurosurgeons are not really comfortable going and doing surgery. So there's a small amount left. We have done stereo EEG and checked whether that particular residual is responsible for those. And we have then fired off with radiosurgery. Patient is having Angel class 1 response. We have also done for drop attacks, corpus callosotomy, and these patients earlier were done anterior callosotomy. Later on, we switched on to the posterior callosotomy. So that's in short about the lesioning what we have been using in our clinic. And there has been renaissance of this particular technique
Sir.
was earlier.
Dr. Shankar,
Yeah.
I think we'll have
Thank you so very much.
one or
for
two
your
questions to be asked. Or we'll ask questions at the end of the session. Now Dr. Vikram will.
I would like to call upon the stage Dr. B.K.M. Reddy sir, Ms. Subhadra, our physicist Subhadra, and Dr. Preetham. I would request you to felicitate the moderator and the panelists. Thanks, Dr. Shankar and the panelists. It was amazing. It was really enlightening and very well done. So we shall go to the next session, and to introduce the speaker and the people following after that, I would request Dr. Gayatri to do the needful.
Good evening, everyone. It is my great pleasure to introduce our distinguished guest, Dr. Joost Newtons. Dr. Newtons has earned both his MD and PhD from Erasmus Medical Center, Netherlands. For the last 2 decades, Dr. Newtons has been at forefront of utilizing CyberKnife in various critical areas like non-small cell lung cancer, pancreatic cancer, and oligometastatic disease. In addition to his impressive work, he is a key member at Holland Proton Therapy Center in Netherlands. We are privileged to have him share his insights and experience with us. So please join me in extending a warm welcome to Dr. Joost Newtons, who will be joining us virtually online. Thank you.
Yeah, I'm sorry, the system does not want to share. So maybe you can put on the presentation. We will present, yeah. So, first of all, thank you for inviting me to having this talk over here. Unfortunately, I was not able to visit your very nice city. It would be great to be in India again. I will talk about stereotactic radiotherapy in hepatobiliary and pancreatic tumors. I mainly will talk about pancreatic tumors, a little bit on the liver tumors, or you can go to the next slide. In the Netherlands, we see quite a lot of patients with colorectal cancer and liver metastasis. However, about 80 to 90% of these patients, they are not resectable, and a large part of them, they are treated with chemotherapy, and the other options are, of course, surgery, radiofrequency ablation, and stereotactic radiotherapy. In our hospital, the stereotactic radiotherapy is the last choice. So if the patient is able to get surgery, he will get surgery. So for the stereotactic radiotherapy, we have good collaboration with the surgeons. So if you can go to the next slide. We treat up to 5 tumors or metastases in the liver. So here under you can see a patient with 4 metastases. This patient received surgery for 2 metastases. We use stereotactic radiotherapy for the metastasis close to the vena cava, and then the small lesion in section 8, segment 8, was treated with radiofrequency ablation. So for some patients we use different treatments to do or to treat the whole patient. So we have a multidisciplinary approach. The patients who are not candidates for surgery and not for ablation are referred to us. We treat a maximum of 5 metastases. Of course, we need adequate liver function, and of course, the primary tumor must be treated. It's also good if the patient can receive after the treatment also systemic treatment. You can go to the next slide. So here in the next slide, we have our indications. Let's say we treat with a maximum diameter of 6 centimeters, although one tumor up to 8 centimeters can be treated. Usually we count the diameter, so if you end up with a diameter of 3 or more tumors with more than 8 or 9 centimeters, then it will be very hard to treat that patient. However, if the patient has maybe 4 or 5 small ones, you also can treat, but then they have to be close to each other. So in general, we say a maximum number of liver metastases is 3. We can treat liver metastasis close to the blood vessel, stomach, kidney, or bowel. We use therefore different treatment schedules. If you have a single one peripheral, then we use 3 fractions of anti-gray. Well, we also have other treatment schedules such as 8 fractions of 7.5 gray, if the tumor is close to stomach, kidney, bowel. Of course, it's important there are no metastases. However, sometimes you also treat patients with 2 liver metastases and 1 lung metastasis. That's also a possibility. So we can go to the next slide. As we all know, the results of stereotactic radiotherapy for liver metastasis is very good. And of course, the quality of life is also good. Dr. Mendes of our department, she showed that quality of life improved 3 to 6 months after treatment. If you look at the EOTC C30 global health status, then before the radiotherapy it was 50, and after 6 months it went up to 55. However, these differences were not statistically significant. So this was my short talk about liver metastasis. Not going to talk about ACCs. We see them too, but not so many. And also, I did not show you the results because they are quite good with 3 fractions of 20 gray, or 5 fractions of 12 gray, or 8 fractions of 7.5 gray. So you can move to the next slide. So then we come to the pancreatic tumors. Is there a light on the horizon? As you all know, patients who have a pancreatic tumor, they have bad prognostic survival. Here we see the results. You can go to the next slide. Here we can see the results of several model single institution trials. All these patients, they had locally advanced pancreatic cancer. The treatment was given of 50.4 gray and 1.8 gray fraction, and they all combined with different chemo. And as you can see, the median overall survival was around 17 months up to 23 months. After these studies, you can go to the next slide. Many other treatments were tried. Here you can see an overview of the median survival of patients who were treated. So if you start with resectable disease, that's only 10 to 20% of your patients. So if they are resectable and you give adjuvant chemotherapy, then the median survival is about 20 months. However, if you give neoadjuvant treatment followed by resection, your median survival is a little bit better, 23 months. In the Netherlands, we did the PRIOPANC study, and this study was closed about 3 years ago, and about 2 years ago we published it, and we only saw that in resectable disease, the median survival was about 15 months, and if you give neoadjuvant chemotherapy or treatment, then your survival is a little better and goes to a median survival of 16 months. So, so that's for the resectable tumors. So if you look to the locally advanced unresectable tumors, if they are eligible for neoadjuvant treatment followed by resection, the median survival can be 20 months. However, if you are not eligible for chemotherapy, then your median survival is only 6 to 10 months, and if you have metastasis, then your survival can be quite low, and the median survival is 6 months. Many studies nowadays show a little bit better results, but many things depend on your patients and your inclusion criteria. You can go to the next slide, please. So, you can go to the next slide. Do you still hear me? Yes, thank you. So for locally advanced pancreas cancers, we treat them with stereotactic radiotherapy, with the endo-ultrasound replace fiducials. This is done under sedation, and it's done with a 19G needle. And as you can see over here, you see nicely our fiducials in there. You can go to the next slide. With stereotactic radiotherapy, you can make very nice treatment plans. As you can see over here, the dose to the stomach, the bowel is really low. You can go to the next slide. So we did the LRBC1 study. That's finished, I think, now 4 years ago. You can go to this next slide, please. Do you hear me? Yes, thank you. So we did the LRBC1 study. This was for inoperable pancreatic cancer, so with advanced pancreatic cancer. They are not allowed to have enlarged lymph nodes or metastasis. We also did a laparoscopy before the start of the treatment, because about 10 to 50% of the patients, they have peritonitis carcinomatosa. If you treat them with stereotactic radiotherapy, it makes no sense, because these patients have small metastases, they will not live longer. We can go to the next slide. So then the first got FOLFIRINOX, we gave it 8 cycles, so that's 4 months. Then after 4 cycles, we did the CT scan. If they had no metastasis, we went on with 4 more cycles, and if they had no metastasis, they were eligible for stereotactic radiotherapy. Our prescription is 5 fractions of a gray, prescribed at 80%. You can go to the next slide. So here you see our CyberKnife, and we also have an in-room CT. With the in-room CT, we imaged the patient daily to see the bowel motions. We made several publications on that. I'm not going to go in detail due to the time. You can go to the next slide, please. From our margins from GTV to CTV is 5 millimeter, from CTV to PTV is 2 millimeter. So in total, the margin is about 7 millimeters. You can go to the next slide, please. And for the next slide, you will see the outcome of our trial. The median overall survival was, for the whole group of patients, 17 months. However, if patients are progressive, patients were included before the start of the chemotherapy. So you see if patients are progressive on chemotherapy, then they were not eligible for radiotherapy, and then you see you have very short overall survival. However, if they are eligible, then you see you have long survivals, and now we have 2 patients who are still alive after 5 years. So this is really a very nice result of the combination of FOLFIRINOX combined with stereotactic radiotherapy. You can go to the next slide. Some of these patients, they got surgery, and as you can see, if patients receive surgery, then they have a better overall survival. The full line is the patients who have no surgery combined with stereotactic radiotherapy combined to no surgery. You can go to the next slide. In the next slide, so this is a summary. So we had 7 patients who were operated. The whole group was 39 patients who were irradiated. So 2 had a complete particular response, and 4 had a partial response. So it's important after the stereotactic radiotherapy, if you can operate, it's good to operate. We can go to the next slide. Here you see a comparison between the studies we have done in the past. First we did the ULAP study, and there you see you can do a few clicks, and then you see median survival of the 2 studies, the FLAP study and the ULAP study was about median survival of 10 months. However, if you combine FOLFIRINOX with stereotactic radiotherapy, then your median survival goes up to 18 months. Nowadays, there are publications where you have median survivals of 30 months. It all depends on your definition of locally advanced pancreatic cancer. You can go to the next slide. If you can go to the next slide. We also used the stereotactic radiotherapy for solitary metastasis in the pancreas. Sometimes the renal cell carcinomas or lung metastasis and colorectal metastasis, they can go to the pancreas. Here we see 3 examples where we did treat these patients with 5 fractures of 9 Gray. And also these patients, they have an excellent response. We made the publication on that a few years ago, so there you can read it. So it's also a very good solution for these patients. If they are not able to be operated, you can go to the next slide. So my conclusion of the talk is liver metastasis and pancreas tumors, they very easily can be treated with stereotactic radiotherapy. The results of liver metastasis and looking from pancreas tumors are good to excellent. I thank you for your attention. Do you have questions?
Thank you, Dr. I think we'll email the questions from our side so that we can answer to our attendees. We'll go to the next talk. Can you please stay back for the panel discussion? Be online, Dr. Nutins.
Moving on to our further panel discussion on locally advanced hepatocellular carcinoma and borderline resectable pancreatic cancer, I would like to call panelists on the stage, please. Dr. Jayant Reddy, Senior Consultant, Comprehensive Liver Care, Hepatopancreaticobiliary Surgery and Multi-Organ Transplant at Apollo Cancer Center, Bangalore. Dr. B.K.M. Reddy, Head of the Department and Chief Radiation Oncology at Apollo Cancer Center, Bangalore. Dr. Sandeep Nayak, Director and Lead Oncosurgery Department, Fortis Hospital, Bangalore. Dr. Sanjeev Sharma, Senior Consultant Radiation Oncology, Manipal Hospital, Bangalore. Dr. Rajiv Lochan, Lead Consultant in Hepatopancreaticobiliary. Unfortunately, he will not be able to join because of the emergency case at his hospital. So, and I would like to call Dr. Mahadev Potaraju, Senior Consultant. Dr. Prasad Narayan for the moderating this session. Thank you. So sorry.
Dr. Prasad Narayan will be in the panel, and Dr. Mahadev sir will be moderating the session.
Over to you, sir. Thank you.
Okay, as we are running very late, I will try to restrict it to 15 minutes. This is not my presentation. So the first case scenario is a patient with a recurrent hepatocellular carcinoma after surgery and TACE with a liver volume of 735 cc and a tumor which is greater than 6 centimeters, located in the segment 4 and 8, CPA. So Dr. Sandeep, what are your thoughts on this case?
I would like to see the scans in more detail, but I think very limited images. I can barely see that, but it's a recurrent case, and
the vessels are free.
Vessels are free.
Yeah.
Means in which way? Like what surgery was done previously?
So initially, a resection of the tumor was done.
So was it left or right hepatectomy? What was the previous surgery? I mean,
left, I think.
Left hepatectomy. See, in this case scenario, if the vessels are free and if the patient is otherwise fit and all the criteria are met, this could be a candidate for a future transplant. Because, in an extended way, he fits into the criteria, he or she. So what happens currently is we could, treat this patient with other modalities of treatment, see how the patient does, and then take care of it or consider the patient on or for transplant in future. It's possible.
So in case you do not have a ready donor for a transplant, how would you manage it?
Yeah. For me? The question is for me
the
again?
question is
Okay, so I would consider a repeat of TACE because this patient has undergone TACE. I would also have an option of tear in this case because it's a single lesion. We could, if it is feasible, again depends on the vascularity and all other factors. Or we could bridge it with radiation. So SBRT would be an option for this.
Okay. So, Dr. Sanjeev, your thoughts on it?
Why there? Asking about the... So, I think I largely agree with what Dr. Sandeep Nayak has said. So, regarding SBRT, given the liver volume and the size of the lesion, it would be a challenging scenario. Not that I would say it is not doable. I think it is worth an attempt, given the location of the tumor. And if a good amount of liver volume can be saved by the usual constraints which we follow, I think doing SBRT as a bridge and considering additional therapy would be a good option.
Okay. Yeah. Can I, Mahadev sir?
Yep.
Yeah, so Dr. Sandeep, I'm a little wondering, the size is around 6 centimeters. Are you still comfortable with TACE? Tear is secondary issue. Even that also has its own set of, but 6 centimeters close to the dome of the diaphragm, I'm not really sure whether TACE is an option which can be explored.
TACE could be an option for 6 centimeters. It should not be criteria. It's a single lesion.
Yeah.
I don't know the vascularity. I don't know where is the location exactly because those details I don't have.
Okay.
But I don't have a strict contraindication for TACE over here.
TACE, okay.
Yeah,
Tear I don't know again.
Tear can be explored, but again the financial toxicity will be
Yes,
much higher.
of course. We are talking theory.
Yeah, Dr. Reddy, you want to say add something?
This is a recurrent tumor.
Correct.
So I think first I would like to go for a biopsy and see whether any other change of differentiation has been happened and also do some molecular markers. Then proceed with the repeat TACE followed by SBRT may be a better option for this, I feel. In view of specifically this size.
So if the patient is unfit for surgery or unwilling for surgery, would you consider any neoadjuvant treatment?
Even otherwise, I think we should see at what point this patient has relapsed after surgery and TACE, right? That is an important point before we say that we will give a local therapy to this patient. So converting this patient to any local therapy, I think there is a very good role of systemic therapy in this situation. And there is data on immunotherapy in combination with bevacizumab, which can be tried if the patient suits that.
Okay. Okay. So this gentleman was basically not fit for surgery. So he was treated with SBRT with 45 gray in 5 fractions. The main liver dose was 13 gray. And till 2 years till now, the disease is stable, under control. This is case 2 with a portal vein thrombosis. Now, it is a histologically proven hepatocellular carcinoma with a portal vein thrombosis. What are your thoughts on this, sir?
So little bit of more information. I assume that there is underlying chronic liver disease. The spleen seems to be slightly enlarged. So there is obviously no ascites. So in the background of this locally advanced hepatocellular carcinoma with macrovascular portal vein invasion, it is, would like to rule out any systemic sort of metastasis. So a PET scan, obviously the
So
tumor
PET CT is done and there are no distant metastasis. So it's basically a 2 centimeters by 2 centimeters histologically proven hepatocellular cancer with a portal vein thrombosis involving both the branches and the main portal.
So in this case, if the patient's child score is low, and then I would like to consider downstaging therapy. Like it's already been alluded to, systemic therapy is a good option. For the portal vein tumor thrombus specifically, you could look at SBRT and TACE for the 2 centimeter HCC before considering any surgical or transplant options.
So would you rule out a liver transplant at all? This gentleman was actually a doctor and he was very keen on a transplant.
Yeah, it wouldn't rule out a liver transplant, but prior to considering this gentleman for a liver transplant, I think we need to downstage it, make sure that the tumor markers are stable, give him adequate time interval, preferably somewhere between 8 to 12 weeks before considering a liver transplant.
You're saying something, sir?
No, with the portal vein thrombosis is a difficult candidate to consider for a transplant. You see, this would all become extended kind of an a scenario where, say, with a treatment, if he improves, something changes. For example, again, here radiation comes into play because radiation can take care of the thrombus. Also, tear comes into play. Tear also they can do in 2 sittings. First for the thrombus and then they can take care of the primary as well. So those things become the primary treatment, but by chance if he becomes fit to go for next line, then it will have to be revised later on. Upfront, no.
So Dr. Reddy, the transplant surgeon sends to you for SBRT for a portal vein thrombosis. That is what the surgeon did. He sent it to us for SBRT to the portal vein thrombus. What is the dose that you would be thinking about?
The dose that can be recommended is anything between 40 to 50 gray in 5 fractions can be given.
Okay. Sanjeev?
Yeah, about 35 to 40 gray in 5 fractions, depending upon constraints, if we can meet them.
Okay. So we treated him with 40 gray in 5 fractions, and 3 months later, actually, there was a good canalization of the portal vein, and he did go for a liver transplant. But within 9 months, he recurred in the peripancreatic region. There was no local recurrence, but in the peripancreatic region. And we ultimately lost him at about a year or so. So recanalization of the portal vein thrombosis happens in almost 15 to 20% of the cases. We have treated around 20-25 patients, but we have our data only on 16 patients with follow-up, and we have given somewhere around 35 to 40 gray in 5 to 6 fractions. So almost around 20 to 25% would recanalize after an SBRT dosage. So a portal vein thrombosis need not necessarily be a contraindication for whatever surgical treatment later on. Maybe it was an over-treatment of doing a transplant for this particular gentleman, but yeah. So what are the indications for SBRT as per the ASTRO guidelines for hepatocellular carcinoma? As a bridging therapy, I don't know how many, as a transplant surgeon, do you send for bridging therapy?
Yes, especially when there is portal vein tumor thrombus. So we have done about 3 patients, I think, Two of them have done well. This is a combination of an underlying HCC with a VP3, VP2 tumor thrombus, not extending into the main portal vein. So in these patients, we prefer to treat the underlying tumor with TACE and or SBRT and SBRT for the portal vein tumor thrombus. And in addition to that, these patients are also on tyrosine kinase inhibitors. But now we could also consider atezo-bev. But the important thing in these patients, I think, is to give that required waiting time to ensure that there is the lesion is stable, the tumor markers are down before jumping in to any form of surgical intervention.
Absolutely. So for a solitary hepatocellular cancer, let us say 3 centimeters, for an SBRT dose, what would you be?
Same, the minimum around 45 to maximum around 50 gray can be given.
Okay. And how much dose would you restrict to the normal liver?
So if the patient has got a normal liver function, the dose to around 700 cc volume should be less than 21 gray. If it is CP score A, it may be around 15 gray. And if it is B, class CP B, it may be around 10 gray it can be.
Okay. So the OR constraints, usually the bowel constraint, we try to restrict it to less than 10 gray. Do we have time for another case? Finish? One more? Okay. So there are about 25 identified studies involving around 1,500 patients for SBRT for HCC, and the 2 years local control usually is around 93%. And the 1 and 2 year overall survival rates around 69 and 54%. You can do in CP B and C class patients also with reasonably good local controls.
Hello. So you can conclude now. We can conclude.
Yeah? Okay. Thank you.
All the dignitaries to stay back because I would like to call upon the stage Dr. Natraj, Dr. Naveen Nagar, and Mr. Gopi Lama to please felicitate the dignitaries. We are actually running short of time, and it's not short of time, it's really, really short of time. So without much delay, I would like to call upon Dr. Sridhar PS, who is the lead in the CyberKnife, and he has got vast experience, and to give his deliberate his talk on oligometastasis.
Everybody is already telling me to rush fast. So I'll be talking about like 6 to 8 minutes. Oligometastasis, you heard about the role of CyberKnife as an SBRT, starting from intracranial, extracranial, and now it's one of the standard of the treatment in many of the cases, especially in hepatobiliary cancers, especially inoperable cases. The size is not really a criteria. Because of the because of the time constraints, we couldn't complete the discussions in detail. So let me rush through. What is an oligometastasis? If you see the incidence of cancers, now we are looking about almost like 14 lakhs patients, cancer patients at 10 new cases, and 30 to 40% of our patients present with metastasis. In terms of prevalence, if you say either in terms of recurrence or progressive, we may land up in getting almost around 40 to 50% of cancer patients across may be metastatic. In coming days, because of the good chemotherapy, immunotherapy, and good surgical approach, we are looking at the number of patients who are surviving is more, and we are going to see more of this particular set of patients who present with stage 4 cancers in one. Especially the prostate cancer, lung cancer, breast cancer, and colorectal cancers, we are seeing a double-digit survival in coming days. That is what we are, the chances of metastasis is more. What is oligometastatic disease? It's an intermediate state between the local and systemic disease where radical or local treatment of the primary cancers and all metastatic lesions might have a curative potential. As the MD students are and MBBS students, anytime if in a stage 4 cancers, if you talk and utter a word of curative, you have failed. So now it is not the scenario. Like now there is a very clearly indication of oligometastatic disease where we are looking at a curative potential. That is important. So there is a clear-cut definition of oligometastatic disease. So in terms of the outcomes, disease burdens, disease type, and like the hypothetically that what will be the stage, what is the biology of the tumor. So there's a clear-cut definitions. The synchronous oligometastatic disease. At presentation, the primary with a metastasis that synchronously is oligometastatic. So that is a different one scenario. And metachronous oligometastasis, you are treated at the early stage going into the stage 3, stage 4. That is another scenario. And oligoprogression. In a case of a metastatic disease on a treatment, a particular disease, particular lesion starts progressing. That is oligoprogression. And oligopersistence. So the disease is already oligometastasis, and all the disease has disappeared or responded. 1 or 2, up to 5 lesions might have persisting. So this is where we are putting into a different criteria. And the best one is the prostate cancers. It is a part of the natural disease. If you say you have seen scenarios, even in a metastatic disease, patients will survive. 10-year survival is one of the things which is known. So that is where we started. And in prostate cancers, the dictum is they make it as a chronic disease and treat as much as possible with a combination treatment. So how we manage the oligometastasis, especially in lung, any metastatic site, please consider for biopsy. And I think that all our oncology colleagues will agree. Genomics is one of the things we are looking at that. The biopsy of these lesions makes a lot of difference. And also it depends on the type of the histopathology and the duration of progression-free survival and all those things. And why it is important, now there is enough data and there is enough immunotherapy agents, targeted agents available. We need to explore these options in combination with SBRT and because of its short duration. Everything started with the Saber Comet, one of this trial, like where the metastatic disease with 1:2 ratios and with a good control and a Saber arm, that is SBRT arm, where they treated the metastatic sites. Please note that the brain mets was excluded in this study because any brain mets, the overall prognosis, what we looked at is only 6 months. But here in as a Saber trial, like we have seen, there is, they treated the metastatic site, especially the breast, lung, and prostate. They were shown the 41 months median survival compared to the 28 months, and which is persistent. Even in the updated data also, it is shown double the survival. And with the least toxicity. The advantage is the short duration, and you are completing the treatment and continuing the systemic disease, which is important. We were talking about the dose. Dose in radiation is one of the constraints, and everybody has, there is no standardized one. As we keep it a range, anything between 5 to 6 gray per fraction up to 7 to 8 gray, or maybe up to 9 to 10 gray. That is 25 to 50 gray in 5 fractions is the one what we usually do it. It is there in the literature. And there is no difference in terms of radical versus a metastatic site lesion. I prefer to treat them as a curative intent full. My best dose, what we'll be doing is 6 to 8 gray per fraction. 30 to 35 gray is the best one to explore the abscopal effect and the immunomodulatory effect, not to go for an ablative dose more than 10 to 12 gray per fractions. That is what we are looking at. And treat all metastatic site. Not to worry about that, it may be a primary or secondary, as long as it is amenable for the treatment, we should do it. There is enough literature in terms of, if you are a fan of a literature or this one, definitely there is enough literature in the one treating oligometastatic disease in prostate cancer, lung cancer, breast cancer, and miscellaneous, especially gynecological malignancy with a para-aortic node, or in terms of the single metastasis, which may occur over a period of 5 to 10 years, we can treat that only, and renal cell tumors. So SBRT oligomets, some of the controversies is some of the people say treat mets alone. That is what this Saber Comet did, and treat primary. That is either to treat the primary or not. That is where in case of HCC, treat only the portal vein. I don't agree with that. So when a lesion of portal vein with the 2.5 centimeter liver lesions, we can treat both, even your intentions of considering for the transplant can be fulfilled. They treat both primary and metastasis, that is what I am looking at. And combination of immunotherapy with SBRT is one of the things which is to be explored, and we are already doing it, and there are a lot of trials for that. Addition of hyperthermia as a poor man's immunotherapy is also an immunomodulatory effect, and definitely genomics is also guide to know that the sensitivity for the radiation is also can be one. So we are already talked about the abscopal effect, how the immunogenic effect of the radiation. So the radiation is no longer a local treatment. So now I'll put it very clearly, SBRT, with the help of the SBRT, we are looking at the immunotherapy, the systemic effect. So these are some of the advantages. So there are radiobiological advantages also, and MDT to MDT, metastatic directed therapy to the multidisciplinary team approach to metastatic disease. We have more than 600 patients treated already. So some of the studies, what we did is, so the lung metastasis, the lung is one of the where brain metastasis is one of the things where everybody told that nothing can be treated. Here in our study, we did around 46 patients, where the patients had a lung lesion with a brain metastasis. We treated all the brain metastasis with the CyberKnife, and also treat the primary wherever it is possible, and all metastatic sites. When we see almost around 328 lesions, this is 328 lesions were treated, and the results are actually, in case where we have treated the lung and the breast, the brain, actually the 27 months was the overall survival in respect to 15 months, and progression, there was no progression in the lung, and in the metastatic sites, 17 lesions were progressed over 257 lesions. So the same with it, so here is what we have talked about is a brain metastasis where the overall survival looked at 6 to 12 months. Now we are talking about 27 months in lung cancer. So these patients also continued with the chemotherapy and immunotherapy or targeted agents. And another is a high volume disease in case of breast cancer. That is where the patients go to a stage that third and fourth line of treatment is given. And here we have seen that in 47 patients, the local control is in the range of 95 to 98% wherever SBRT is given.
Can we?
And the prostate cancer, this is one of the
next session?
Yeah, there's two more
Sorry.
slides. Two more slides. This is 35. This is one of our first publications, which is done almost around 7 years back, as like in terms of stampede trial. Treat the primary with the prostate and the metastatic, oligometastatic lesions. We have seen almost the 5-year survival was 87.5%. The most of the times it's a progression in the other one. In renal cell tumors, with the actually in case of SBRT, the response we see in renal cell tumors. There is a complete responses which occurs. If you keep the range of 35 to 40 gray per as a total dose in 5 fractions, that is good enough. And the biggest advantage is like with the help of the TKI, we can go back and retreat as much as possible. And we should go for the definitive intent in these cases. To conclude, definition of oligometastatic disease, low versus high volume, it may be borderline. As we are talking about more than 5 centimeter in HCC is a big lesion. I don't consider it really a one. So up to 8 to 10 centimeter, we can deliver very good treatment. And there is no need to give any margins. That is an advantage when you are talking about treating with SBRT. Upfront, sandwich and consolidate, that is another one. And SBRT to the primary site, I always recommend. And radical versus palliative, give full radical dose. There is definitely a survival advantage. Re-irradiation is a possibility in these cases. And immunotherapy with combination is definitely one of the things we have to look in combination with the SBRT. I appreciate your patient hearing. Thanks.
Thank you, Dr. Sridhar. We are coming to the last bit of our session, which is a panel discussion on metastatic CA breast. I would like to call upon Dr. Jadhav, who is the moderator, and he's a senior radiation and a HOD of radiation oncology in Apollo Cancer Centers, Delhi. The panelists are Dr. Vishwanath, who's a medical oncologist he's senior medical oncologist in Apollo Hospitals, Bangalore. Then Dr. Anil Kamath, who is a senior surgical oncologist at Apollo Hospitals, Bangalore. Dr. Jayanti, madam is there? Yeah, she's a senior breast oncologist and a breast surgeon at Apollo Hospitals, Bangalore. And Dr. Vijay Bhaskar, Dr. Vijay Bhaskar is a senior radiation oncologist and with a vast experience in radiation oncology. Dr. Jadhav, please make it.
Good evening, everybody. I think we are going to skip some slides, coming to the case directly. Okay, now let me welcome the panelists. Now this is your first case. A 46-year-old lady presented with left breast lump and back pain. On a PET CT, the FDG showed both breasts, all quadrants, avidity, FDG avidity, and D7 vertebra PET scan positive. Her ERPR were negative, HER2 new positive. Ki-67 was 40%. Biopsy from the spine was positive for malignancy. Now this is a clear-cut case of oligometastatic carcinoma with bilateral breast. Now the question in general is bone a good site for biopsy in breast? Anybody can take the call.
I don't. Yeah. So unless there is a fracture of the bone which needs to be fixed and surgical intervention is done, we may not go for biopsy of the bone.
Correct. Because you cannot run the IHCs to get genomic markers on that, on a bone particularly. But if there is a soft tissue component, then it's worthwhile doing that. Then what is the percentage or will the hormone receptor or HER2 new negative, HER2 new status change on bone biopsy?
Yes, there's definitely a discordance, and because of the decalcification of the bone, it may be difficult to get the ERPR and HER2 status on the immunohistochemistry on the bone.
It's very difficult to get genomic studies on this decalcified bone. So bone is not confirmatory for receptor status. Then how do you manage? SBRT you want to do, or do you want to do a neurosurgical decompression? This is a general question again.
SBRT is certainly an option. We can go with a single dose SBRT 20 to 22
Yeah, but if there is a neurosurgical, if there is a neurological symptom, then you can ask for a decompression and then proceed with SBRT. What about the primary treatment? Would you still go ahead with treating the primary? Just now, Sridhar gave a wonderful lecture on that.
Yeah, since this is only metastasis, I think we should go with the curative. Yes.
Yeah, it's worthwhile treating the primary with full zoom. So what we did an SBRT to D7 directly with 27 gray 3 fractions. She received 6 cycles of TCH regimen chemotherapy, followed and Herceptin as well, and she underwent MRM bilateral because both the breasts had FDG avidity. On post-op histopath, it was YPT0N0. Hence, we proceeded with radiation to the bilateral breast and to the drainage areas. Now, as you see by this abstract, it is worthwhile going for a surgery of the primary tumor in stage 4 for survival benefit in metastatic patients. So the follow-up scans, she had a disease-free interval for 6 months. PET-CT was negative, but later on, the PET-CT done post 6 months showed 2 nodular lesions in the cerebellum. This is how we got to see the 2 lesions in the cerebellar region and confirmed on contrast enhanced MRI. There are 3 lesions on doing an MRI now. So would you like to get a brain biopsy? It's a free call.
No,
I'm not
I don't think it's not mandatory.
Yeah.
I think if the suspicion is high, we can proceed with treatment without a brain biopsy.
Brain biopsy.
So just want to
But
add.
patient is asymptomatic.
So any of the the PR positive with the metastatic disease at presentations, usually we do a brain MRI upfront along with the PET scan. So because as we see that within 6 months it has come back. So there is always, like in our own study, we've seen that 20% of the patients where PET scan does not show the brain metastasis in MRI has picked up. So probably the early MRI is better in metastatic.
No, but earlier MRIs, I have skipped some slides here because of the paucity of time, because I got a call from these guys. So the MRI, previous MRIs were all negative. So would you like to do a decompression as patient is asymptomatic or a stereotactic biopsy?
So since we have 3 lesions and there is no extracranial spread of the disease,
Exactly.
I think, SRS is a good option here to consider.
I agree with you.
And
So patient, sorry.
And it's a low volume disease as per the MRI is concerned.
Yeah, there are no intracranial tensions or anything like that. So there was no question of decompression. And stereotactic biopsy, the patient refused. So now, let me direct it to the radiation oncologist.
Dr. Jadhav.
Would you like to proceed ahead without a biopsy with radiation?
What is the disease-free interval between the brain meds and completion of local therapy?
6 months.
6 months. Still, you would like to give radiosurgery in such situation?
But there's no extracranial because the other parts of the body.
But the disease-free interval is less than
Disease-
6 months.
Only brain disease.
The D7 settled down.
6 months.
Shankar, the D7 settled down. So there was nothing added
nothing was done.
on follow-up PET scan in D7. Now we found in the brain 3
But
lesions on an MRI.
That means Herceptin is not working. Definitely biopsy is required.
Yeah, but the patient refused biopsy. That's what it says. So
SBRT, no problem, sir. But for future treatment, because R2
Only
is
thing
not working.
So, there can be a discordance. So that is something which is important for medical oncologists. So there can be change of ERP or HER2, ER in around 15%, PR in around 30%, and HER2 around 5%. And most likely it can be kind of a down regulation. So something which is ERPR positive could be negative. So that is something which is important for medical oncologists.
okay, we'll be coming to that now. So the option was to do a whole brain with SIB or to do an SRS or FSRS. So we chose to do what you call an SRS. Any other differential diagnosis would you like to put?
No, sir. I would go with a proper MRI study.
Yeah.
Maybe
Any other
perfusion
additional
and,
radiological studies?
Yeah, MRS and
MRS.
perfusion study.
So we also come to what is called as a multi-parametric MRI. So what do you do in multi-parametric MRI? In multi-parametric MRI,
Sir, can we wrap it up in another 2 minutes?
Okay.
Another 2 minutes.
Only one case I'm doing today.
Okay.
We do diffuse weighted imaging, DWI, perfusion weighted imaging, and magnetic resonance spectroscopy. Now DWI provides information about cellularity and water movement. Perfusion weighted gives information on angiogenesis and vascularity, and MRS gives about composition of various metabolites in the tissue. So this is what you get in the multi-parametric MRI. So as per the MDT, we decided to do radiosurgery, 30 gray, 3 fractions. I will not go into these trials. I'm cutting short. Now to the medical oncologist.
So this
role of
patient,
systemic treatment and what drugs?
so this patient has got intracranial disease and HER2 positive. So now we know that the HER2 space is quite wide. A lot of new drugs have come. So we could give TDXT is a one fantastic option.
Correct.
Trastuzumab deruxtecan, or there's a combination of trastuzumab plus tucatinib plus capecitabine based on the HER2 climb. And now there's HER2 climb 2, where you have TDM1 with tucatinib. So many new drugs, such a fantastic plethora of drugs in this HER2 space.
Which can cross the BBB as well.
Exactly.
So, but this is an old case, 2021. So we decided to give Herceptin with Lapatinib and received 17 cycles of Herceptin. And we have already discussed about anti-HER2. So on follow-up, contrast-enhanced MRI later showed no disease. But then again, post-SRS, 11 months later, you could get to see 2 lesions. Now, your view on the viability of the disease. Is it a recurrence, pseudoprogression, or is it radionecrosis?
It's more of a edema, sir. So I would like to wait for some time and repeat an MRI.
Exactly. Okay. So this is how this question was framed, just to ask for recurrence versus pseudoprogression versus radionecrosis. So I'll not go into the details now because he's already sent me a buzzer there. So the time frame for a pseudoprogression is 6 weeks to 15 months, and in about 9 to 30%, of this brain metastasis, you find that. Usually the treatment is steroids. Radionecrosis, 6 to 24 months after SRS treatment, incidence is 5 to 25%. So, but here unfortunately the spectroscopy showed positivity.
I don't agree.
Colon peak. And the DOPA PET scan, our MRI had broken down, PET MRI, the DOPA PET MRI. So instead of DOPA PET MRI, we did a DOPA PET CT. And that showed uptake of the DOPA lesion then. So perfusion again showed enhancement. So after much deliberation, we decided to counsel the patient for a surgery. So patient underwent a craniotomy and a surgery of the brain, of the cerebellar lesions. And there comes the bomb. It was a radionecrosis. It was very surprising and very interesting case for us. So this is what I would like to highlight, that even a DOPA failed, even the MRIs failed, perfusion weighted or, and that's where that misled us to thinking that this is a recurrence. Though the initial MRI showed it more thickened lesions with enhancement, that it could be a pseudoprogression. So the histopathology finally came as a radionecrosis.
Low-dose bevacizumab is one of the things. Actually, we can use it in a post-radiation necrosis.
Yeah.
And especially in 10:3, when you're giving, there is always a chances of necrosis. 5 fractions, probably the chances of necrosis is also less.
Okay, now.
And moreover, in this case, we needed a biopsy because she was HER2 plus and she was on herceptin
That's
for
question for actually,
17
see,
fractions.
why you are taking it as HER2 positive only and we are
Maybe
continuing.
SRS 5 fractions are lesser dose, maybe 24 gray in 3 fractions, not 30 in 3. This is what I feel.
It's an interesting, nothing is what you call hard and fast that you have to follow. See, you can be right, I may be wrong, I may be right, you may be wrong. It is all your practice, how you go about it. So, in nutshell, I would like to say metastatic breast cancer is a heterogeneous disease, and wherever you find oligometastatic breast cancer disease, you should go all out for a radical treatment rather than a palliative treatment, because they stand a very good chance of a cure. And the overall survival rates are 82% at 10 years and 53% at 20 years. You can imagine it's a normal life, one can expect. But it is not clear if it is due to more favorable tumor histology, biology, or to the effects of treatment, modern day treatment. Okay, with this we end today. Thank you so much.
Sridhar, can you just come up on the stage? I would like to invite Dr. Dinesh Madhavan, Dr. Manish Mattu and Dr. Neema Bhatt, if she's there, to felicitate our dignitaries.
Next time, very oligometastasis conference.
It's a very vast topic actually. Very
nice session, sir. Thank you. Very nice. Thank you, sir.
Namaste and good evening, ladies and gentlemen. As we conclude today's CME Radio X event, I extend my heartfelt gratitude to everyone who made this event a success. I deeply appreciate all the speakers and participants who joined us in person and virtually and sharing your knowledge and insights which have greatly enriched our understanding of robotic radiosurgery. A special thanks to Dr. Cian Collins, Dr. Newtons, who took time despite of the time difference, and Dr. Ian Paddock for their invaluable contributions. I would also like to express my gratitude to all the panelists and clinicians for attending the event. Our journey at Apollo Cancer Center's aims to provide world-class cancer care. The launch of CyberKnife S1 and CK Academia here in Bangalore marks a significant milestone in our mission to advance cancer treatment. A sincere thank you to our dedicated clinicians, nurses, and entire Apollo family. Your relentless and expertise are the cornerstone of our success. Thank you all for your presence and participation today. I thank you and look forward for your future interactions. I request all to join for dinner. Thank you.